Thank you for introducing me. I have no specific disclosures, and I should say that I'm doing another talk on Wednesday, so whatever we don't cover today, we'll definitely be talking about it on Wednesday, the 5th of August. The main things, what we wanted to cover today is mainly about the pharmacology in pain medicine, mainly to describe the role of opioids in pain management, including safe prescription, and discuss the use of other medications in pain management, such as the tricyclic antidepressants, the SNRI group of medications, gabapentinoids, and definitely touch upon medicinal cannabis, which has been a very popular question, and definitely discuss the role of the multidisciplinary pain services and when to refer to a specialized pain clinic. I'll try to keep my talk as much as possible to evidence, though a lot of it in pain medicine sometimes lies in ideas and opinions or case reports and case series, or there's been extrapolation from other studies. But also would like to share a lot of the lessons I have learned moving into the field of pain medicine from being a rheumatologist and a general physician. So I would definitely like to share some of the tips and the tricks which I've been using in the pain clinic. And as I said, I would like this to be as much as possible a discussion between each other, though I can't see you and probably you're all muted, but just feel free to ask any questions or type in any questions, and we will try to pause frequently to take some of the questions. And before we proceed, I think there's a common question which I get in the clinic. Took the pain pill and why are you still here? Or I'm on 100 milligrams of OxyContin and why is the pain still there? Probably to set the scene, once upon a time, just a story which happened about 2 years ago when I was working for the Dementia Center and supporting the DBMAS and the SBRT programs. Pain, pain. Pain, pain, he screamed, for how long I know not. Pain, pain, he screamed, why I know not. Pain, pain, he screamed when he was usually alone. Pain, pain, he screamed, then more medication started to quieten his voice. Pain, pain, he screamed, even more than before. Pain, pain, he screamed, then shifted to the last room in the home. No one heard him scream anymore. Pain, pain. And this was some of the cases which was referred to me when I was working in the Dementia Center, and this was an aged care facility. Particularly there, the question was this, what's the role of pain medications in people with dementia, particularly when they're not able to verbalize, or how much to give, and and the effects of sedations, the effects of falls, and the side effects. So it goes on to the next question, mirror, mirror on the wall, which pill to give all? And before we answer that question, probably think having a bit of an understanding of pain becomes important. René Descartes, back in the 1664, had drawn this picture. This was even before the discovery of nerves, prior to which pain was always attributed to the clouds or miasma or things outside, or the curse of the gods. And he'd kind of drawn it to say that if the foot was exposed to a fire or a noxious stimuli, the message was carried to the brain through a hollow tube. And this did kind of revolutionize a little bit about the way we started looking at pain, or in fact looking at the body itself. And in acute pain, this model worked very well, where when someone is pulling out teeth, or when we look at this on this image itself, that itself can trigger pain within a lot of us, and as an alarm or as a need that something needs to be done. And this led to the search for the fix of pain, and we have so much better imaging today, new medications, surgeries, and still many times we struggle to kind of fix the problem of pain. And so very often we have people who've had back surgeries, but still structurally they look okay, or many times the surgeons say the MRI looks perfect and everything looks good, and the question still comes, why are they in pain, or why do they still need medications? And this kind of goes back into the chronic pain model, though we do use an arbitrary term that if the pain has been present for more than 3 months, then it's kind of been termed as the chronic pain or beyond the expected time of healing. It would kind of come into the chronic pain criteria, though people do argue that whether we can kind of predict that some people might end up having a more persistent pain early in the picture or even before they've undergone a surgery. And many factors for pain to kind of lead to the state. Some of the things is what sort of narrative we tell about the pain. Catastrophization has always been noted to be one of the modifiable factors, and people who catastrophize more have a higher degree of pain interference. This is again something which has been noted in a lot of studies, particularly with chronic pain. And with catastrophization goes magnification, a feeling of helplessness, and kind of ruminating on the ideas are some of the factors. And coping strategies is another one. People with a low self-efficacy do have a higher pain interference or a higher pain intensity. And sometimes even the words, what we use, words such as degenerative, can add different meanings to the pain, or the words when we say bone on bone. So all of these do kind of lead to more fears, lead to more emotions, which kind of affect the way they can cope with their pain. These days, again, with internet and people searching for more answers, are they somatizing more? Do they become more hypervigilant about their symptoms? All of these do contribute. Emotions play a strong role. We know that anger, fear, and sadness do go hand in hand with pain, and sometimes the pain fuels the anger, or the anger can kind of maintain their pain perceptions. Cultural influences play a big role. I always say, like in our house, when I was growing up, I never spoke about pain, and maybe if I spoke about pain, maybe I would get a slap and say, "Come on, move on." Or whereas in my wife's family, it's completely different. If she complained of pain, she'd get a hug and a paracetamol. So again, the cultural influences matter not only in the way we manage it, but also in the way we communicate pain. And definitely a lot of other studies to kind of say early developmental stressors, childhood stressors, and other life stressors do play a role. It's not that everyone with early childhood trauma end up having chronic pain, though there is a slightly higher risk, and it depends on how each of them process their trauma. And again, aging plays another role in both physiologically and due to the changes in the environment into how pain is being perceived. Coming back to the definition of pain, very recently, the International Association for the Study of Pain have redefined the definition, prior to which it was defined as an unpleasant sensory and emotional experience associated with the actual or potential tissue damage, or described in terms of such damage. The problem with this definition was the use of the word described. So again, what happens if people are not able to describe people with aphasia, people with dementia, or animals? So I think that led to a whole debate which has been going on for many years, and they have changed one word. Instead of described, now they use the word resembling. So it's an unpleasant sensory, and very important to remember, it's an emotional experience associated with or resembling that associated with actual or potential tissue damage. And the reason potential tissue damage comes in is we know that, like in conditions like fibromyalgia, there is no tissue damage, or many times even with chronic lower back pain, there is no identifiable tissue damage. And coming to the definition, as we spoke, there's been some additional notes to the definition that pain is always a personal experience and is influenced to varying degree by the many factors which we have discussed, and it's always beyond the biological, psychological, and social factors. Pain and nociception are different phenomena, but we'll briefly touch upon it, and it's very important to recognize the difference between nociception
and pain. And pain cannot be inferred solely on the activity in the sensory neurons. And through their life experiences, individuals learn the concept of pain. And a person's report of the experience as pain could be respected. Although pain usually serves an adaptive role, it may have adverse effects on function and social and psychological well-being. And verbal description is only one of the several behaviors to express pain. Inability to communicate does not negate the possibility that a human or a non-human animal experiences pain. In going back to the definition of, another definition of pain, this was in the notes of the previous definition, where an activity induced in the nociceptor and a nociceptive pathway by a noxious stimulus is not pain. Pain is always a psychological state. And in palliative care, sometimes they have another definition, which again sometimes is useful, where they call it as total pain, as the physical, emotional, social, and spiritual dimensions of distress. So looking at it from that perspective can also be very helpful at times. And this kind of led back into kind of redrawing the figure which René Descartes had done, looking into the many aspects of pain, into the sensory discriminative aspects, the cognitive evaluative effects, and the affective and motivational components to pain. And again, they say the lateral pathways help more in the sensory and the discriminative aspects. The medial pathways help more in the affective and motivational pathways, and the descending pathways play more of a role in the cognitive and evaluative pathways of pain. And this becomes important because it can also help us tailor some of the treatments to the different pathways which could play a role in the person's pain. And this is a figure of the pain pathways, starting again with the nociceptors, which are being activated and going into the peripheral pathways, the dorsal ganglion, which then kind of connects onto the second degree neurons in the spinal cord, taking the message up to the spinal, through the lateral spinothalamic tract into the brain, and from there it goes to different paths. And this becomes again important because different medications can target at different levels of this pathway, and some of them can react at more than one site. The other type of pain, it's also sometimes important to kind of differentiate what could be the possible sort of pain. Occasionally there are overlaps, or many times there are overlaps, but knowing about the nociceptive pain, where it's the activation of nociceptors, which can be like in rheumatoid arthritis or osteoarthritis, or after a fracture where there is an acute trauma, whereas neuropathic is now defined as something where there is identifiable lesion of the somatosensory nervous system, which is either diabetic neuropathy or a post-stroke pain, whereas nociplastic pain is where it's a disturbance of the central processing pathways of pain, where there is increased excitability or a reduced inhibition of these sensory changes, which is what is probably identified as the mechanism in fibromyalgia, sometimes commonly also termed as central sensitization. A similar phenomena is also identified in temporomandibular dysfunction, sacroiliac dysfunction. Complex regional pain syndrome does have an element of nociplastic, particularly in type 1. And again, to recognize that amongst all of these biomedical factors are surrounding by the psychosocial factors which lead to the total pain experience. And again, speaking about the different medications or which can be used to kind of inhibit this pathways to kind of reduce the experience of pain, have been kind of listed in this figure. You will all get a copy of these slides in a PDF at the end, so there's no need to take any notes. It's sometimes important to recognize all of this because then we can tailor the treatments according to the person. So coming back to some of the take-home messages, is pain experience and expressions vary from person to person, and the pain assessment is a whole person assessment, and person-centered care is vital, and this is what kind of helps us determine what is the best medication for each person, or what's the best treatment because medication is still form only a single part of their entire treatment or management process. And many times just expecting to put a pill and kind of help all the issues, especially the psychosocial issues that each person undergoes, can be pretty challenging. And again, we know that one size does not fit all, probably except for handcuffs, I believe. So then again, the next question comes is, what pills should we add in the water supply to solve the problem of pain? I might just take a small pause here. If there are any questions, I'm happy to answer them.
We do have some questions, but they're mostly on specific medications. So if you want to keep going,
I think we'll keep going, and
we'll talk about those. Yeah, thank you.
Thank you, Jen. Again, I mean, there are many stories coming back into medications. Just sharing some stories from some of the people I've seen in the last couple of days. Yesterday I saw a 92-year-old who's an aged care resident, had bad cellulitis of her leg, and she's on 75 milligrams of fentanyl patch. And the GP's question was, what shall we do with her? She's kind of completely bedbound. Should we leave her on the dose, or what would be the best pathway for her? Or I had another lady who was in her late 70s. She's had a diagnosis of psoriatic arthritis. Been put on multiple steroids. She's gone through at least 6 different types of biologic medications and has not responded to anything, and has still widespread pain. And she was asking to me about the role of medical cannabis. And another young 40-year-old who's been on OxyContin 80 milligrams 6 times a day, and he says that kind of helps manage his pain, and he's been on that dose for 10 years for back pain. They could not see any imaging or anything to kind of see what is going on, and do we continue that treatment, or what is the next best option? Or another 42-year-old computer engineer who has had again back pain with a referred component down the leg, and he's afraid even to use paracetamol because he thinks he would get addicted, but is very happy to have a surgery to his back. And so these are some of the common scenarios that we get referred upon, apart from many other situations. But I just thought I might start off with some of them to see how we can kind of modify and help them to move from suffering to a much more better state. Unfortunately, I've been practicing as a pain physician for at least the last 3 years. I think doing a computer graphic is much easier than getting a victory through a medication change. It does happen, but not every day, or definitely maybe one a week or even less. Mirror, mirror on the wall, which is the best medication after all? And I think in the Cochrane done a review to kind of see, after a single dose of oral analgesia for acute post-operative pain in adults, what's the number needed to treat. And they looked at different medications from paracetamol to Benadine, ibuprofen, and Gabapentin. And basically they said how many people had at least a 50% relief after 4 to 6 hours. And if you look at the number needed to treat, it's still more than 3, I think was the lowest. That's for naproxen. But again, it shows that not everyone have pain relief, and this is looking at 50% pain relief. So a degree of acceptance is always needed. Drugs like Gabapentin, the number needed to treat is around 11. This is for acute nociceptive pain. For neuropathic pain, the number needed to treat is about 7 for Gabapentin, and tricyclics there have a number needed to treat of 3. Again, coming to an image which probably many of you might identify, the opioid group of medication. What's the difference between opiates and opioids? I think opiates are drugs which are directly derived from the poppy seed, whereas the synthetically derived components which work on the opioid pathway are called as the opioid group of medications. And it's kind of had a long history where people have used different sorts of opioids, starting out with heroin, and this is back in the late 1800s, where people could get a sample by writing to them, and it was used for sedative and cough. And very soon, people did realize the addictive properties, and different products or different opioids have since been synthesized. And every time people have said they've had lesser addiction or lesser properties of harm. Mirror, mirror on the wall, which is the best opioid amongst all? I would say the answer is think carefully. Probably there's none called the best opioid. It's about kind of titrating it to what's the person's context and what is the role, what are we trying to achieve by using these medications, because we do know that there is a lot of long-term harm, particularly when used over many years or decades. And, just coming back a little bit into, we will talk a little bit about individual opioids, but some safe precautions to take just as we prescribe. One is the 5A principle. We're looking at what is their analgesia, in the sense where is their pain, what's their possible causes of pain, having a pain formulation, looking into what are all the determinants of pain, not just the pain intensity on a scale of 1 to 10, looking into what activities they've not been able to do, and once we start the medication, seeing how much it improves not only their analgesia but also how much function they're able to do better. Is it improving their sleep? Are they able to go back to work? Are they able to walk more? Is their quality of life improved? All of that becomes important determinants. And again, balancing it with adverse effects and what's happening to their general mood becomes an important thing. And definitely keeping an eye on if there is any aberrant drug-taking behavior. And definitely worth screening the opioid risk tool, particularly before we start anyone on opioid therapy, and always having an exit plan or having a duration. How long should we treat? Like when we start antibiotics, we say let's give it a week or 2 weeks. So always having an end date in mind sometimes becomes very important with opioid medications. We do know that people with with a family history of alcohol or substance use, or even a personal history, have a higher risk, or untreated psychological diseases play a risk factor. It's not that these people should not be given opioids, it's about making sure how do we safely monitor it, or taking more precautions there becomes important. Coming to two important synthetic opioids, and the tramadol and the tapentadol. Both of them are combination opioids, and some of the main differences between them is tramadol is a prodrug, gets metabolized through the cytochrome system to becoming into a more active metabolite, whereas tapentadol is an active metabolite, and it does have an SNRI property. And so I think that's where there are advantages of tapentadol compared to tramadol. At the moment, tapentadol has been in the market for about 10 years, and the studies have kind of shown the lesser likability of this drug, or lesser cases of addiction. Again, this is something which sometimes is hard to identify until they've used it for many, many years. But at least compared to when people were given oxycodone and tapentadol, people preferred using oxycodone compared to tapentadol. This is among the people who used substances. So again, that's another reason where some people are tending to use tapentadol more, and sometimes the SNRI effect has also been found to be helpful. Coming to my own general in the practice where I've seen a lot of people, especially the elderly, do not necessarily tolerate tapentadol very well. The main side effects being nausea, vomiting, feeling very sleepy or drowsy has been a common effect. Occasionally, some people don't like the SNRI effect and feel very restless. And if people are on very high doses of opioids and when that's been suddenly stopped and changed over to tapentadol, definitely when we look at the opioid conversion, 100 milligrams of tapentadol is equal to 30 milligrams of oral morphine. But when we change someone from on 30 milligrams of MS content, for example, and straight into tapentadol, they could have a withdrawal. That's because the 30 milligram of tapentadol is more an analgesic equivalent rather than an opioid equivalent. I do have a few patients who do take a lot of tapentadol, much more than what they should be. So it's not that tapentadol is completely free of any dependent or addictive issues. And definitely there are a few cases of overdoses with tapentadol, particularly when mixed with other medications. The other commonly used opioid medications, particularly in the elderly, is buprenorphine. Again, wouldn't start off in acute pain, but many times in people with more chronic conditions, it definitely is an useful medication, particularly the Norspan patch. Though buprenorphine is a partial agonist, what we do know that when we use it as a patch, when we use other opioids with it, it does not necessarily have a negative effect in that context. Definitely when buprenorphine is used in the context of opioid substitution, where we use 2 milligrams of buprenorphine or 8 milligrams of buprenorphine, in that context, it can reduce the efficacy of other opioid or sometimes trigger an opioid withdrawal type of effect. But I think that's very unlikely, and it's been proven that even if someone is on sublingual or even on Suboxone, and when they come in for acute pain, these days we do not stop the Suboxone, but we just give them more opioid than what we might use in somebody who's opioid naive. There's a whole lot of other opioid medications, and again, depending upon different contexts or based on what is available, we choose different opioids, whether it's the morphine, the oxycodone, codeine. It's kind of a bit of a trend to move away from codeine, I mean, especially away from Penadine. I mean, a part of it was sometimes people do take a lot more codeine, in which they end up with having paracetamol-related toxicity, and codeine is metabolized, is a prodrug, again needing the cytochrome P450 mechanism to be converted into the active metabolite. And different people have different metabolism pathways of codeine. So I think the general trend is to use a more agonist type of a medication if needed. And the issues with fentanyl, especially with the patch, the problem is many times, which sometimes in aged care facilities, we did notice someone would come and they had a patch of Norspan starting at 5 milligrams. The next day or 2 days later, they noticed that the patch was not working, or the person still had a lot of pain. So they increased the Norspan patch to 10 or 20 milligrams, and it's still not working 3 days later. And then they shift them over to fentanyl at 25 milligrams or 50 milligrams. And the following day or so, they notice that the person is narcotized or has been difficult to arouse. And something to remember that with the patch, especially with Norspan, it can take up to 3 days to reach steady state. And with fentanyl, though, 12 micrograms of fentanyl is roughly equivalent to somewhere between 35 to 50 milligrams, and 25 micrograms is roughly equivalent to 75 to 100 milligrams of oral morphine. So definitely would not use fentanyl, particularly in somebody who's opioid naive. The difficulties again with fentanyl, especially if they've been on it for a long period of time, is every time we drop the dose down, we drop it down by 12 micrograms, which is roughly about 40 milligrams of oral morphine equivalent. So there's no smaller increments to decrease down the fentanyl, particularly if they've been on it for a long period of time. So I think sometimes tapering it down or weaning it down can have challenges. But with our other lady who had earlier mentioned, was in her 90s, She was on 75 milligrams of fentanyl, and just suggested that we kind of drop it down to 62 micrograms, and then kind of add a bit of endone or Telexia immediate release if needed for breakthrough pain. But in the period of 4 weeks, she was able to come down to 25 micrograms when I last spoke to her, and she did not notice any difference in her overall pain levels. In fact, she was feeling much better. She said she was cognitively much more alert on a lower dose. And this is something what we notice with a lot of people on high doses of opioids. They're initially very reluctant to reduce it, particularly if they've been on it for a long period of time. But when we kind of allow them to kind of give them some freedom and say that we're going to try a small step down, many times they are happy to come on board. And sometimes I do use an analogy which another pain specialist kind of was using. It's almost like getting into a swimming pool. The first time we enter, the water feels cold, but once we are there for a few moments, we do get acclimatized to the environment, which is something which happens even with opioid. Each step down, when made very at a small level, initially to gain their confidence, becomes important. And once they're shown that they're able to reduce without kind of worsening their pain intensity or function, a lot of people do kind of agree to go down and do feel much better at times. Mirror, mirror on the wall, how much opioid after all? And again, the most important thing about opioid, it's not only about which opioid we use. It depends upon what dose we use, and one of the most important thing is the opioid dose equivalent. And this chart is available on the FPM website. There is an app if anyone wants to download. And this sometimes becomes very helpful, particularly to explain to our patients into how much oral morphine they're using in a day. And also to notice that like buprenorphine or Suboxone, 2 milligrams is roughly equal to 80 milligrams of oral morphine, or 100 milligrams of tapentadol is 30 milligrams of oral morphine, and fentanyl patch conversion is 3, and buprenorphine is 2. What you would notice is that there is no conversion directly for methadone. Methadone works on different pathways. And when we are starting it as a new patient, we use the conversion of 1:3, whereas if we are, 1:20, but if you're trying to convert back from one opioid to methadone, we always start it at a very low dose, as it has a huge range. These are, again, this is the app for the Opioid Calculator. This is a very important, a very nice website, both for the patients and for health professionals. It has a lot of good videos. I mean, for everyone, there's one on spinal cord injury. Very soon there'll be one on the traumatic brain injury and pain. There are a few nice ways to kind of look into for patient resources into what they can do, explaining what is pain, what is the role of medications, looking into a more multidisciplinary approach to pain. And the quick steps, again, become a useful resource to kind of see when and where who should be referred. And currently, I think there's a whole, I think most of the guidelines across the world have kind of saying about 60 milligrams of oral morphine is probably a more safer dose. They do show that there is a linear relationship between dose and analgesia until a level of 60, after which it kind of becomes a bit more less steep, and definitely over 120, it almost plateaus over there, where the risk of adverse effects outweigh the risk of a positive benefit. And this is something, again, to be aware of. However, these do not apply in a palliative care setting. That's something, again, to remember. This may not apply, again, in an acute pain or in a cancer pain. setting, though even in cancer pain, they are rethinking a bit on how much opioid to use, particularly as we see more cancer survivors these days, and a lot of that group of population have been on very high doses of opioids, and after their cancer has been treated or they've been completely cured, they're still left on being dependent on a higher amount of opioid. And again, this is the New South Wales regulatory authorities. A lot of you must be aware that they have changed the way PBS is giving authorities for these, and where now if someone has been on opioids for more than 12 months, they need another doctor's review, which can be anybody in your own team or a pain specialist. Not everyone need a pain specialist, but if someone is on more than 100 milligrams of oral morphine and they're difficult to get down, I would definitely recommend them to be referred to a pain clinic, or less than or more than 60 and still again struggling, just to see what other measures can be applied to kind of reduce the overall opioid dose. And if anyone is on an S8 opioid, either methadone or hydromorphone, particularly for more than 2 months, then we need to get an authority wherein we fill up this form and send it across. This is different from the PBS authority. What we get, this is an authority to the pharmaceutical services in New South Wales. And again, coming back into why did they choose the dose of 120, sorry, I think the lower x-axis is cut off here. This group is, the first group was 0 to 50 milligrams, the second group was 50 to 100 milligrams, and the last group was between more than 100 milligrams of oral morphine. And definitely, as the dose went up, the odds ratio of the risk of overdose definitely increased, and so did the adverse effects. And for most of them, as the dose increased, the amount of the odds ratio is nearly 2 to 3 times increased risk of adverse effects. And even drug-related mortality, I think recently there was a study which looked into tramadol in osteoarthritis, and people who were on long-term tramadol had a higher mortality compared to people not on tramadol. Definitely, people when benzodiazepines are combined with opioids, the risk increases even further. And again, there is a bit of a dose correlation there too, whether both of them are synergistic and leading to more respiratory depression. So again, something to be aware of, particularly as a lot of our people who are on higher doses of opioids do receive some form of a benzodiazepine. And what really triggered a lot of this opioid pathways have been the trends, particularly in the States and even in Australia. We were seeing kind of similar trends, though we were a little behind the States. And just as oxycodone use increased, so did the use of other synthetic opioids or heroin use also increased, and there were more deaths due to prescription opioids in the States. And that's definitely something which we are trying to address. And many times, many of these people, though they were on high doses of opioids, it did not necessarily help with improving their quality of life or providing them their functional goals that what they were looking for, particularly over 100 milligrams. Again, there are some people who do well on high doses of opioids. And again, there is a role of opioids, but to kind of weigh it and see which is the safe zone. And again, making sure we take all the precautions when we prescribe becomes important. And again, as this chart kind of very beautifully says, that a lot of people with pain problems use opioids, and there are a smaller number of people who take it due to substance dependence. And this is something to be aware of, that they may be exhibiting drug-seeking behaviors, but they simply are asking for better pain relief. And that's something to be mindful of. And just to, again, lots of studies again showing that people who are under the workers' compensation scheme or under insurance scheme are on a much higher dose of opioids than people who are not on a comparable population, not on the legal issues. So that's something again to recognize the different stresses related to the workers' compensation and other contributors which could be leading to their predicament. Coming to the adverse effects of opioids, again, plenty from sleep disorders to cognitive effects, which are very common. And a lot of people with pain in general can have memory deficits. And again, the combination of other medications they're using. Dry mouth is a very common side effect and leading to poor dental hygiene or needing dental treatments. Gastrointestinal side effects, nausea and constipation. This is much more common again in the elderly or people who are more sensitive. Many people who have been on that for a long time, some of these symptoms, some of the adverse effects, they do get used to it and become less. There is an hypothalamic induced suppression of the gonadotropic hormones, so people do end up with hypotestosteronism, and that can lead to osteoporosis. So again, that's something to kind of make our patients aware, and increase sweating and pruritus are other side effects apart from becoming dependent or becoming tolerant on these medications. Again, in people with cognitive deficits, it's very important. Again, it's not that if someone has dementia, they should not have an appropriate pain medication. There may be a role of an opioid, and sometimes if it is incidental, if identifying if the pain is at the time of personal care, then do we use a short-acting agent to kind of time it to that particular functional activity? Sometimes it works well, or sometimes if they're not able to verbalize, or in aged care facilities, if sometimes getting S8 medications take a whole lot of process, and especially if there's one nurse RN overnight. So in that context, using a longer acting agent at night or using a patch at a low dose can sometimes be helpful in that population. But again, the bigger question has always been about the risks of opioids. How much does it make their memory worse? And does it increase the risk of falls? At one point, I was looking into the literature to kind of see if it can help me direct what to do in that context. I think there's no one clear direction. Having uncontrolled pain itself increases the risk of falls and causes cognitive deficits. So at the same time, being cautious about what we use, and again, trialing it out for a few weeks at the low dose and seeing what difference it makes can sometimes be helpful. And again, this is some of the medications which one could consider for opioid withdrawal, particularly as we are decreasing the dose, which can either be antiemetics or using clonidine. Sometimes I do find propranolol is another useful thing. Avoid using benzodiazepines though. It's kind of used occasionally when they are admitted in the hospital and we are doing a very rapid taper down of their opioid medications. And if someone is on more than 150 milligrams of oral morphine, I do recommend them to have a naloxone. And currently, the New South Wales Health provides free naloxone, either in the form of an injection or as an inhaler. And there's a whole list of pharmacies where they can go and pick it up. It doesn't need a script. And so again, once again, the link is there, which will be available to all of you through a PDF. And this could be something what you can share, particularly if you are concerned about aberrant use, or when they're taking more than what they should be using and come up for early pickups in those people with high distress, or people who are on a lot of other benzodiazepines or other medications which could cause sedative at a higher dose. Once again, this has been helpful, at least more as a safety point of view, and this can also help educate their other family members. And when starting people, or every few months, I mean every 3 months at least, I would suggest 3 to 6 months to kind of verify with the prescription shopping information service. Hopefully soon we may have a live tracking system, and sometimes to recognize this is not live, it covers the last 3 months, and it may not have the most recent data at times. And the other thing is it identifies anyone who has more than multiple prescribers or more than 25 items, and no patient consent is needed. The only thing is it doesn't pick up any private prescriptions. And unfortunately, there's no notification process on who are the other doctors who are prescribing. Now, I would strongly suggest, if you all have time, to definitely look at this. This is called the Better Pain Management module. This has been designed by the FPM and SCA College. There are many, the Better Pain Management module has about 12 modules into providing a multidisciplinary approach for pain management, and this is tailored to different health professionals. There's also another module on just opioid management, which is free at the moment. I think they give 8 of the 8 modules out of the 12 modules is freely available, and I recommend all of you to have a look at it. And again, there is a whole talk on pharmacology of pain medicine. It kind of goes back a little bit more into the rationale and how do we make a decision on which medication to choose for different management. And this is another medication, again, useful resources both to patient and to ourselves, is through the Faculty of Pain Medicine in UK. Coming back, I might pause here for a moment. If there are any questions on opioids, we may take that before we go on to the last bit of the talk.
Yeah, there's a couple of questions on medication. Might do those. A patient with a fracture needs opioids, but he gets an itch from the atypical ones actually. Tramadol, Targin, Palexia, probably all opioids. What alternative can you use if Mobic and Nurofen have affected blood pressure and renal function?
Again, tricky. Sometimes it's about seeing whether we can use a lower dose. And occasionally antihistamines is an option, or in this circumstance, again, using a low dose of gabapentin along with an opioid has sometimes worked. Depends again on which fracture site. But normally in this context, I might use a bit of gabapentin. Usually, sometimes people do use very low doses of naloxone, which can help with itch. Though administering it and getting it can be an issue.
And when you mentioned naloxone before, you can get it from pharmacists if they're on a high dose of morphine equivalents. Is it just if they feel drowsy? When do they use it?
Largely, it's I think rather than drowsiness, I think there's it's mainly when they are not being arousable. And usually, I know it's hard when they are self-using and there's no one around. It's usually kind of letting people around them know that if there's somebody who's not being able to be aroused, that may be a time. Initially, again, it's first to ring up for help, ring up the emergency service, and they can administer it. And again, there's no harm. I mean, in the sense, even if they give it to somebody and if they do not respond, it's not going to necessarily cause any adverse effects. And hopefully they've called, the first thing they do is call up for the emergency help. And as they're waiting for the ambulance or emergency services to arrive, they would have been given the naloxone.
Thank you. And I'll do one more before we progress on. There's 2 similar questions, basically about breakthrough pain if you're already on atypical opioids like Palexia or Norseman, or if you're already on methadone. What do you use for acute pain or for breakthrough pain in that situation?
This again, it depends on the context. Like if they have, let's say someone is on methadone and then they have a fracture, In that context, again, we would kind of see, is there anything else we can do, like a local nerve block if they are in the hospital setting? Again, trying to optimize their non-opioid use, whether they can be given anti-inflammatories, regular paracetamol, and seeing is there a role of any nerve agents. And if they are on methadone, definitely a couple of options there. Again, speaking to their drug and alcohol specialist, if they're happy for us to, one, slightly increase the dose of methadone as an option, or occasionally in the hospital setting, we have used oxycodone or using other opioids on top of it. So there is no, I mean, in the end, people do respond, but its only thing is about being aware that when we increase the dose, that we also have a plan to decrease it. If they are on Norspan patch, again, there is no interaction when we add other opioids. Like if they are on a Norspan patch of 10 milligrams, giving Pelexia or Endone will not reduce the efficacy of those medications. But again, it's once again thinking about, is opioid the right solution? And if someone was not on the Norspan patch, whatever analgesic regimen we would have planned for them, trying the same regimen again would still be my first go. And occasionally it might be about reassuring and kind of seeing what's exactly the context over there.
Mm-hmm. Thank you. Well, we might keep progressing because I know there's still some more questions, but a lot of them are on cannabinoids as well. So if you want to keep going, then we can ask all of them at the end. Thank you.
Yep, we'll touch on that very soon. I think this is just a study done by Finner up in Europe about looking into the number needed to treat for neuropathic pain for different agents. Particularly in that context, some common drugs we use apart from opioids would be low dose of nortriptyline or amitriptyline. The Gabapentin group, again, is widely used, though the number needed to treat can vary between 5 to 6 and 7 sometimes. The SNRIs, again, come into the 6 or 7 group for the number needed to treat. We use capsaicin topical. SSRIs have a lower role in pain, though they can be helpful from a mood point of view. Topiramate, valproate, carbamazepine are more useful in headaches rather than in peripheral neuropathy itself. And I do use a lot of topical lignocaine, particularly if they have cutaneous sensitivity, people with peripheral nerve injuries, people after wrist or hand surgeries, and shingle or post-herpetic neuralgia, or people who are intolerant to medication. Sometimes when we've used a compounding cream with either lignocaine or amitriptyline, people do tolerate it better. It doesn't work for deeper pain, does work for more superficial cutaneous sensitivity. Sometimes after a total knee joint replacement, people have had injury to the saphenous nerve or have an area of paresthesia or dysesthesia. So in that context, again, using a compounding cream has helped them. Doesn't solve the problem, but definitely brings about more function there. The downsides about compounding creams are they are expensive, and there's been one study where they've used cannabinoids in neuropathic pain. Again, most of the evidence is more towards amitriptyline or nortriptyline, which has a number needed to treat of about 2.7. Some of the other medications sometimes we use is ketamine, though again, they are looking into a more meta-analysis to see what the role is. In a few placebo-controlled studies, ketamine has shown to be statistically not any different from the placebo. There are a few other studies where it definitely has a role in post-operative pain. In my own experience, in someone with long-standing chronic pain who are not on opioids or on very low dose of opioids, giving a ketamine infusion has not necessarily given a prolonged change. They do feel better when they are on the infusion. They may feel, many of them feel good on the day they leave the hospital, but some of them within a week or within a few weeks are back to where they are. So it's not always a sustainable pathway. The main group where, again, not with 100%, but one group of population where it has been helpful is people who are on very high doses of opioids, and want to come off it, definitely it has allowed them to kind of significantly reduce the overall opioid dose, sometimes even to zero over a very short period of time. Ketamine is also used in the form of a topical cream, though these days it's much more harder to get it. Lignocaine is another medication which is available in the infusion form. Again, quite good for neuropathic pain. I think that's where a lot of the evidence is someone is having very bad post-herpetic neuralgia, especially the elderly, and they're intolerant to a lot of the different medications, the gabapentinoids, the opioids. Sometimes this can be an effective solution, though there are risk factors. I mean, it does need cardiac monitoring, making sure there are no arrhythmias. But again, I found them quite helpful. Occasionally, we use ketamine and lignocaine for difficult to treat migraines or in headache settings. It has had, in my personal experience, I don't think it's helpful for some, but for many people, not necessarily very helpful. Pain patches can again be helpful. The lignocaine 5%, again, depending on the area of the pain, if there is cutaneous sensitivity, and if it is a region where they can wear a patch and it doesn't peel off, definitely in that group it's helpful. And sometimes when they're not able to wear a patch, in that context is when I've suggested them to have a compounding cream made up. I usually use 5% lignocaine, sometimes prolocaine or tetracaine for a longer effect. Occasionally add a bit of amitriptyline or gabapentin, particularly if they're not taking it orally. Again, this is just a bit of list of few things, and if they have CRPS type of symptoms, which can be either swelling or color changes, clonidine is another medication which we can add. Capsaicin is again helpful more in a herpetic neuralgia picture. Again, to notice that to start with a very low dose, otherwise the cream itself can cause more pain or itch. There's a lot of other complementary medications which people use for pain, particularly in osteoarthritis. The more commonly known ones are the glucosamine, the chondroitin, turmeric. These days are very popular. Magnesium is another one which a lot of people take for spasms. And again, there's a lot of studies coming, or at least there's an increased popularity of PEA, which is palmitoyl ethanolamide. And again, people have suggested different pathways for its effect. It does probably have a bit of cannabinoid effect. It's basically a fatty acid which is present along the neural coating. Usually, they're suggested to take 400 milligrams 3 times a day for about 2 to 3 months. And if they notice a positive difference, they are asked to continue but they can down titrate it to 2 tablets or 1 tablet as they require. A lot of people ask me about diet. This is, again, no one specific food, but looking into a healthy diet definitely helps. Occasionally, I do find colchicine helpful, not only just for gout, but also in inflammatory arthritis. That could be something one can consider, but again, to be careful about renal function and to kind of keep the dose low becomes an important aspect. Coming to cannabis, very interesting time, and there's definitely a lot of news about it from different aspects, both medical research and from marketing and from different organizations. It's been very hard sometimes to tease out where the truth lies. And the 2 main components, one is the CBD or the cannabidiol component, and the other is the THC component, which is psychoactive. If someone looks into the TGA applying for cannabis, I think there are over 150 or maybe even 200-300 combinations of different medications ranging from a pure cannabidiol component to 1:1 CBD and THC and 1:25 CBD THC. And coming down, again, if you look at the TGA approvals in the last, I mean, this was in 2019. I think there's definitely an increase since May of 2018 to 2019, and I think the highest, and then the indication has largely also been largely used for chronic pain, has been one of the bigger reasons for trialing medical cannabis. There's an FPM statement. At the moment, the Faculty of Pain Medicine do not kind of support the use, or rather than support, they do not say that it should be used for everyone. They kind of say they don't endorse the clinical use, but they say you can use it in a very careful or a trial setting, is at least the college's, the faculty's position on cannabinoids. And the main reason is at the moment, when they've done larger meta-analysis studies, there have not been many studies to kind of show a statistically significant improvement. There's only one study which compares cannabinoids to Penadine, and again, they found no statistical difference in pain relief between cannabis and Penadine. The similar thing with when they tried it against amitriptyline / gabapentin, they found the amitriptyline and gabapentin to be more effective. So we're still waiting to see where the evidence goes, though saying that it's very easy these days to access cannabis. A lot of people around the eastern suburbs have either tried cannabis from their friends or have had access to oils, or when they've traveled up to Byron Bay, they can get it off the markets. But recently, another study which looked into the quality of these products in Byron Bay, they kind of looked into 100 different street available products, and many of them did not have any cannabinoid product itself. So I think there's no standardization over there. And again, we at this point of time also do not know about the long-term harms, particularly, though I think I mean, in the few patients, I mean, in the 20 or 30 patients under my care who are on cannabinoid products, I think the more common side effects have been nausea or vomiting. Cost has been a big factor at the moment. A lot of people do not find value for the money, and some people do find it helpful. It doesn't remove all their pain away, but it can help with their anxiety or sleep. So some people use it in that context. Some people take THC / CBD product in the evening, but do use a pure CBD product during the day. And currently in our legislation, if someone is on THC, legally they should not be driving. So if they ever end up with an accident or with a legal issue, they could be under trouble, or probably insurance may not cover them. And the other thing, again, to remember particularly about medicinal cannabis is there's a huge interaction with the different cytochromes. So again, to be careful about prescribing medications which can act on the cytochrome systems, particularly antibiotics or other pain medications too. We do know that codeine and tramadol do need this CYP2D6 mechanism, and this is a table showing different cytochrome-based systems. Just again, another safety, but this applies more to any opioid, particularly methadone type medications, is definitely to look at the long QT intervals. So if someone is on methadone, to kind of routinely check their ECG, particularly before starting, and on an annual basis. And again, when we are introducing other medications which can prolong QT interval, to be very careful if they are on methadone. I think that's a risk to be just aware of. And the other thing to be cautious about in other conditions such as hepatic, if someone has hepatic cirrhosis or hepatic dysfunction, then kind of choosing which medication to choose, definitely if they have liver failure, to kind of reduce their overall dose of paracetamol, or completely avoid a similar thing with the anti-inflammatory groups. Again, the opioid, particularly morphine, and their metabolites do accumulate. So does hydromorphone, sometimes fentanyl or buprenorphine is probably a bit more safer in people with liver disease. Gabapentin and pregabalin, we don't need to dose that just because it's largely renally excreted. So that's something to be aware of. And if they have renal impairment, again, to avoid any anti-inflammatory type of medication, once again, in this context, using low-dose hydromorphone, fentanyl, or methadone are probably a few more safer medications. If anyone is using gabapentin or isn't gabapentin, to kind of reduce the dose of gabapentin or pregabalin, particularly if they have end-stage renal disease or GFR less than 30. In the elderly, and particularly those with cognitive deficits, using kind of being aware of the anticholinergic burden becomes important. And many medications we use, including opioids, tapentadol, duloxetine, and the tricyclics, all have a high anticholinergic effect. And in fact, there are calculators to look at it. And people with a higher anticholinergic effect increase the risk of falls, make their cognitions much worse. And definitely looking into polypharmacy in the elderly is something to be constantly keep an eye upon to reduce the interactions between the medications. So coming back into summary, for whenever there's inadequate control of pain, it's always worth reviewing. Is there a mismatch between the pharmacology and the physiology? And sometimes just increasing the dose can lead to increased side effects of an ineffective drug. So seeing whether we can target the approach, and using multimodal analgesia, using medications from different mechanism of actions can provide a synergistic effect and can also decrease the overall dose needed. And thus, keeping in mind the whole person, their choices and comfort become important, using measures, whether they like heat or cold, simple touch. Movement is, again, a very important thing, making sure we use all of this. And again, being cautious about what physio we do. Again, active therapy is helpful, but passive measures have been shown to be less helpful, particularly if they have long-term pain. Being very aware many times following manipulations itself, people end up being much worse off, or whether they have acupuncture or chiropractic treatments, or surgeries to kind of fix their pain. I've not touched a lot today about interventions, but we will definitely speak a bit more about that on Wednesday, particularly about the different interventional procedures which one could consider, whether it's radio frequency to the medial branches supplying the facet joint, or pulse radio frequency. These days, radio frequency techniques, people have been working more on the knee joint, like doing radio frequency ablation of the geniculate nerves of the knee, the shoulder joint, the hip joints, particularly in those who are not suitable for surgery or have already had a surgery and still have persistent pain. And I have noticed pulse radio frequency sometimes at the small joint, particularly the first CMC joint, again, working very well in that context. The only risk about all of these procedures are sometimes the risk of coming to theater, sedation, and the use of steroids in these injections can be something to be aware of. And definitely psychology is a very important part, and many times people are not necessarily very willing to kind of engage with those services, but taking time to get them on board is helpful. Seeing what other, kind of keeping an eye on the complementary use of medications can be helpful. It's not always about increasing their pain relief, but sometimes it's about looking into the context of seeing what's going on. And many times kind of education and hearing the person takes a lot of time, and probably very therapeutic too at the same time, into explaining why, even if they took the pain pill, they're still in pain. And many times it's about reframing their expectations and narratives, and that's where again the psychologist or a psychologically minded physician/physiotherapist play a bigger role in pain management, and sometimes using motivational interviewing type of techniques, and not increasing medications just because of how loud they scream or just based on distress levels can sometimes lead to risk factors. And again, trying to avoid short-term fixes at times and looking into different aspects are very helpful in pain management. This is the online pain program from St. Vincent's Hospital, in looking into all the needs of the family to become important, and what they would have wanted should probably guide us on how we go as we reduce the pain intensity. I think I'll stop here.
Okay, well, thank you very much for that great talk. There's a lot of excellent questions that are coming in, so I'll just try and get through some of those, if that's okay. With the cannabinoids that you haven't answered, you've answered a lot of those. Patients, how does the patient know which to choose if they're given a list of suppliers, that they're actually getting a pure one without THC?
Yep, I think a lot of time it's cost, but nowadays the cost is the same. Particularly if they're driving, I think probably then I would suggest to maybe trial the cannabidiol component first and see how it goes. And again, with everything, it's about starting low and starting slow. And again, having an endpoint to see what are the goals they want to achieve, or what do they want the cannabis, what aspects of their function do they want it to be changed? Is it pain relief? Is it improving their sleep? Is it their ability to sit down for 1 hour? So kind of making sure we know their goals before we start is very helpful, because sometimes people have just kept escalating the dose of the different cannabinoids, and going through that journey of trying the various cannabinoids itself can take a year or 2 years before finding that it doesn't work, or people can still go down the slippery pathway of saying we've not found the right dose or the right cost yet. So I think I've normally used either the pure cannabidiol version, usually starting with the 25 milligram concentration, or the 1:1 THC, and starting at 1/4 ml and seeing, generally up titrating and seeing the side effects and keeping a close eye. Most of my patients do have a psychiatrist review, or have had a psychologist review.
And we have a lot of other questions on the other drugs. Do you have a favourite TCA and dose? And what is the what do you prefer, amitriptyline or nortriptyline, with some of the questions in the elderly?
Yep, I prefer, in the elderly, probably none. I mean, in the sense, if I had to choose one, nortriptyline definitely has a lower anticholinergic effect compared to amitriptyline. Again, starting very low, 5 milligrams to 10 milligrams. From a sleep point of view, 5 to 10 milligrams is a good dose. From a neuropathic pain perspective, again, can start from 5 to 10 to about a maximum of about 50. And I think anything more than 50, I mean, I normally don't go there, but my psychiatrist, our team psychiatrist, definitely has a lot of people on 100 or 150 milligrams. They do find it as an effective antidepressant, but dry mouth and urinary issues, constipation, weight gain are some of the side effects which we very commonly encounter.
And one is that if you're on analgesia for OA, Tarjan, Norspan, Tramadol for a year, should the analgesia change to a different type if they're already on atypicals?
I've sometimes changed it largely to kind of do a bit of an opioid rotation. Sometimes when we rotate, if they've been on a single opioid for a long time, if the dose is kind of less than 20, 30 or 40 milligrams of oral morphine equivalent, then I kind of review down to see if going down to the same medication, like if they're on an Norspan 20, then would 15 do the same role, is something which I always keep asking them at every few months or every 2 to 3 months, doing the review there, or sometimes saying, rotating it to kind of see, sometimes that can also allow to reduce the overall opioid use. So have offered it, but it again depends on where in the cycle of change the person is and what's again the risks and the benefits of each of them, something to be questioned about.
Mm-hmm.
There is no public medication.
Sorry. Gabapentin versus Lyrica. What do you feel the difference between them is?
Again, with gabapentin, we have a huge range to up titrate, starting from 100 milligrams up to 1,800 milligrams. The problem with gabapentin is initially it has a steady state absorption. As we increase the dose, we get a good effect. But after 1,800 milligrams, there's kind of a bit of a plateauing where increasing from 1,800 to 3,600, we don't get a similar increase in the benefit. But the advantage of gabapentin is sometimes some people respond well to even 100 or 200 milligrams. And with Lyrica these days, for most of my patients, I start at 25 milligrams, kind of get them used to it before going up to 75. To be aware that there is addiction and dependence with gabapentinoids, definitely has a high street value. That's something which is becoming more and more aware. So definitely if someone is on 300 milligrams 2 or 3 times a day, you would question into should they be on such a high dose for a long period of time.
Right. And someone's asked, are the procedures that you mentioned, the radioablation, are they rebatable at all on Medicare?
They are rebatable on Medicare. Most of all the radiofrequency procedures are, depending upon where you get them in the public clinic, like Prince of Wales, RPA, North Shore, they do have interventional pain physician. Like in St. Vincent's, we don't have an interventional pain physician wing. In the private, if they have private cover, then I think it's completely, I think there's no gap for these procedures.
Mm-hmm. And another question, what opioids would you recommend for a 96-year-old living at home? Normal cognition, has severe pain and the need to do osteoarthritis. Panadol osteo is not helping, and they're on rivaroxaban.
Sure. I mean, depends. I mean, again, this is going to be more in the context of improving function. I mean, if it is only, if she's able to sleep well and it's only during the day or related to a particular activity, sometimes one could use a low dose of endone could be an option at 2.5 milligrams and seeing how she goes. We could use tapentadol or tramadol, but I would be a bit cautious, particularly keeping with the age and with kind of physiological changes. Probably a very low dose of endone or liquid morphine, even at 1 or 2 milligrams, in which she can use it. But if it is a much more constant issue and it's interfering her sleep and interfering a whole day's activity, in that context, probably Norspan 5 milligrams may not be a bad option.
And someone's mentioned with the opioid packaging being in small quantities on the PBS, how do you manage acute severe pain and follow up reduction in dosing? Has that been a problem for you?
Huge problem. Huge problem. Since a lot of people, when they're discharged, especially with the current COVID environment too, it's not always been easy to get to their doctors. A lot of restrictions. People don't want to move out, and there are definitely a lot of value in giving short packs. Though patients don't like it, like some people in the hospital discharge are using about 8 tablets of endone a day, and if you give them 10 tablets, that just lasts them for 1 day, and they're not very happy. But again, it's about reviewing them. Fortunately, we do have the phone service these days, so probably keeping constant contact. I have my workload has definitely increased, particularly because we need to get more scripts and sometimes more often. We can get authority. Getting authorities are not, that process has not changed, but definitely there is a useful change to make us all think about how long they should be on it and how do we continue it.
And someone's asked, what is the mechanism of osteoporosis for opioid use or overuse? Was that just the central testosterone effect from the pituitary hypothalamus, or was there something else you mentioned?
I mean, I think the main thing what they have noticed in long-term use of opioids, opioids itself maintain pain because of the negative effects on the glial systems and the increased adverse effects. And I think those have all been reasons where, and in studies, they've not necessarily improved function. And all of these are reasons where they do not recommend opioids for management of long-term osteoarthritis pain, particularly if you're 40 or 50, 60 years old, you have another 30 years ahead, and relying just on one methodology is not going to be helpful. People are going to become tolerant. So maybe using whatever we use, using it as a crutch to allowing them to kind of get back into exercise therapy, get back into non-pharmacological ways to deal with it, still becomes an important pathway. But some people might still need it, so it's always individualized. Sorry.
Yeah. No, that's good. Someone's asked about interesting question about constipation and bacterial gut dysbiosis, saying it's common increased age and it can be induced by morphine with a subsequent decrease in analgesic effect due to reduced intrahepatic morphine pathway. Is there any comments about this? Re potential for escalating dosage, as morphine can induce gut dysbiosis and increasing potential for dependence.
Possible, but there are other mechanisms where they have shown opioid tolerance. I think one of the main common reasons is there's a dissociation of the mu receptors and the cyclic AMP pathways. So though they're having more opioids, that doesn't stimulate the inhibitory effect. And probably that's been mentioned more. I'm sure there may be some studies. I've not necessarily come across that. Sorry, I'm probably not aware of that.
Mm-hmm.
Though coming to fibromyalgia and other pain conditions in general, there's a huge interest about gut microbiome and pain, but I've not come across it in the context of use of morphine.
And you sort of mentioned this before. How do I try to bring a patient who's been on endone and Phylexia for 4 years off the drugs? The condition was for severe chronic anorectal fistula for 4 years, but it's healed now.
Yep, and again, it's about, it does take a lot of time and engagement. Initially, I do try, I never reduce anybody's opioid. I mean, when I see them as a new patient, I personally do not reduce them usually on the first appointment unless there's huge safety concerns there. It's normally about spending some time getting to know the person, engagement, and then kind of seeing if they can, getting them to reduce it by small doses, seeing what are the psychological barriers to why they're not reducing it. And finally, if they never kind of reduce it, a couple of things is whether we get another doctor to review it, or those could be times when we use refer to the pain clinic, or kind of say this is what the law states, or using this is where the guidelines are about using at least bringing them down to 60 milligrams of oral morphine equivalent would probably be the first step.
And someone's mentioned chronic pain at the lateral thigh, burning pain, Lyrica not helping. What other options? Is that neuralgia paresthetica?
Yep, two common conditions. One is neuralgia paresthetica, trochanteric bursitis, occasionally from the L5 radiculopathy, or when people have had surgeries to the back. All of these can lead to burning pain along the thigh. Sometimes compounding creams, again, depending upon when the interference is high, one can consider a block of the lateral cutaneous nerve, of the lateral femoral cutaneous nerve, or even do a pulse radiofrequency around that. Basically, you're giving radiofrequency waves around the femoral cutaneous nerve. These can be some options, again, or using other analgesics could be an option. Weight loss is again a helpful measure in that context.
I often see that in truck drives, or people who've put on weight and they're in a sitting position all day in a truck.
Yep, and gabapentin itself can cause weight gain and kind of play a negative role here.
And someone's asked, would a genicular nerve block help if you've got patients with knee pain?
Yes, definitely. I have. I mean, there is a lot of data to show it does help. Compared to the facet joint, the geniculate nerves are not kind of attached to a bony position of the knee, so there are chances that when we do a burn, we may miss the nerve. So sometimes people do cool radiofrequency where they burn a bigger part to catch the nerve. And we don't burn there are 4 geniculate nerves supplying each knee. We don't burn the lateral inferior geniculate nerve because the peroneal nerve runs close to that. But we do burn the 3 superior medial, superior inferior, inferior medial, and superior lateral geniculate nerves.
Well, thank you. It's 9 o'clock, and we've had a lot of great questions. So thank you so much for answering all of those. And thank you also for such an interesting talk, Dr. Anand. Thank you for